So today we are going to go through intrauterine fetal demise, also known as stillbirth. So stillbirth has replaced intrauterine fetal demise as the terminology of choice, now based on the opinions of parent groups. So particularly in this video, we are going to use IUFD and stillbirth interchangeably. So the United States Center for Health Statistics defines a fetal death as, so this is the definition for fetal death and not for IUFD or intrauterine fetal death, but just fetal death standalone. So we are going to define it as a delivery of a fetus showing no sign of life, as indicated by absent breathing, heartbeat, pulsation of the umbilical cord, or definite movement of voluntary muscles, irrespective of the duration of pregnancy. That's fetal death. Then, what about definition for stillbirth? So, which of course is intrauterine fetal death. So, we say this is fetal death which occurs after a defined gestation age and or fetal weight, both of which have historically lacked uniformity. So you can end the definition on the weight. So currently the most recognized definition of stillbirth is a fetal death that occurs beyond the age of viability or at a birth weight greater than or equal to 350 or 500 grams. So like we said, uh, these definitions are historically lack lacks uniformity. So the second one is the most one which is recognized, so don't forget. Okay, then the causes of intrauterine fetal death are classified as maternal, fetal, placental, and others we have iatrogenic and idiopathic, which is also known as unexplained. Then globally, unexplained stillbirth is the most commonly reported cause in 75% of cases worldwide. Then, so we are going to start with the maternal causes or maternal risk factors for IUFD. So we have maternal conditions such as DM, we have hypertension, thyroid diseases, and we also have pre-existing diseases such as heart disease, anemia, epilepsy. We also have infections such as malaria, hepatitis, influenza, syphilis, toxoplasma, sepsis, and of course obesity, which has been proven and it's modifiable, so it's not necessarily always, but you can even modify it. So it's a modifiable risk factor. Then we are of other autoimmune disorders which can cause, such as systemic lupus erythematosus or SLE, and also and phospholipid and phospholipid syndrome, which is known as APS, which is presence of lupus anticoagulant, then also anticardiolipin antibodies caused by Desudia vasculopathy with fibrinoid necrosis. We also have placental vesicular atherosclerosis and intervenous thrombosis, and beta 2 glycoprotein 1 antibody. So this is just additional data for you to know that to diagnose APS you need one clinical criterion plus one laboratory criterion should be met. Then we have other causes such as thrombophilias, such as factor 7 Leiden, protein C, protein S deficiency, hyper hyperhomocystinemia. Then mechanism is similar to APS. So the mechanism is similar to the one we were talking about. Then we have hyperpyrexia. Then we have RH incompatibility, cholecystasis of pregnancy. We have abruption, which is placenta abruption, PPROM, multiple gestation, They also have labor related such as preterm dystocia, uterine rupture, prolonged or obstructed labor. Then we have, of course, smoking, alcohol, drug abuse, and advanced maternal age, and specifically more than 35 years old. So we have also fetal causes, which include intrauterine fetal growth restriction, which we have significant increase in the risk of stillbirth in the associated conditions which we are going to say. We have if they are fetal aneuploids, fetal infection, maternal, smoking, hypertension, autoimmune, obesity, diabetes, and also other fetal causes, chromosomal and genetic abnormalities, structural anomalies, infections. So it could be virus, bacterial, or chorioamnionitis. And then we have RH incompatibility and eye drops, both immune and non-immune. Then we have multiple gestation and G6PD deficiency. Then we have placental causes such as placental abruption, which is the most common cause, EA, under placental. Then we have also, since we are going even to include cord, even if we haven't separated it, but we are going to put cord accidents such as prolapse, true knot, cord around the neck. Then we have placental infarction and placental insufficiency, placental or membrane infection. So example is chorioamnionitis, PROM, placental previa, twin to twin transfusion syndrome. Also have fetal maternal hemorrhage, iatrogenic, so it could be due to ECV, which is your external cephalic version, drug overdoses, and of course other causes. We can have iatrogenic and idiopathic. So under iatrogenic we can have external cephalic version. We can also have drugs such as quinine beyond therapeutic doses. Then under idiopathic we can have the causes which remain unknown since they are unexplained up to now, and they are the most common ones. So even with thorough clinical examination and investigations, their causes under idiopathic, they remain idiopathic, of course. Then we have, though this is just additional information, but we can have causes of fetal death based on trimester. So these are not the causes of intrauterine fetal death. Uh, these are just causes of fetal death, as in the one we talked about. So differentiate since the definition of intrauterine fetal death or stillbirth, we say beyond when the pregnancy has reached the age of viability, and the age of viability depends in if it's in a developing country or developed. So you may have above 20, above 22, above 24, above 28, just depending on the definition. But these are just generalized for any fetal death. So we can have first trimester fetal death, such as causes can include chromosomal abnormalities, environmental factors, e.g., medications, smoking, toxins. We can have maternal anatomic defects, e.g., Mullerian defects. We can also have endocrine factors such as progesterone insufficiency, thyroid dysfunction, diabetes, and of course unknown. Then under second trimester, we can which occurs, and this is an MCQ question where they ask you the first trimester ends at how many weeks. So don't say 12, it's 13. Yeah. So second trimester begins at 14 to 27. So we can have causes such as anticardolipin antibodies. Remember, these are found in even in APS, we can find them. Then we have antiphospholipid antibodies, chromosomal and abnormalities, anatomical defects of uterus and cervix, erythroblastosis, placental pathology conditions such as circumvalent placentation, placental previa. Then under third trimester, which occurs 28 weeks to full term, so we can have anticardolipin antibodies, placental pathology conditions such as same ones. So we can have circumvalent placentation, placental previa, abruptio placenta, and of course infections from toxoplasmosis, CMV, and parvovirus. So okay, then we are going to classify them. The stillbirth, we can classify them as macerated and fresh stillbirth. So what's macerated stillbirth, which is MSB? So this is the dead fetus which undergoes an aseptic degenerative process called maceration, and the epidermis is the first structure to undergo the process, whereby blistering and peeling off of the skin occurs, and this appears between 12 to 24 hours after delivery, after death, not delivery, after death. Then we have the fetus. So after that, the fetus will become swollen and looks dusky red. Then it gradually aseptic autolysis of the ligamental structure and the liquefaction of the brain matter and other visceral takes place. So there will be liquefaction of other visceral organs. Then the changes vary in degree and are responsible for the characteristic radiological signs which we are going to talk about under examinations and investigations. Then, of course, the last thing we want to talk about under the classification, we can have fresh stillbirth, which is the dead fetus which has not undergone a degenerative process or changes, which occurs in the intrapartum period, which is, of course, during labor, and death of this fetus occurs in less than 8 hours before expulsion. So, how do you make a diagnosis of fresh stillbirth? So, not fresh. How do you make a diagnosis of stillbirth? So, either macerated or fresh stillbirth, apart from the time we've talked about. Okay, so repeated examination are often required to confirm the diagnosis. So we have symptoms such as absence of fetal movements, which were previously noted by the patient. We can have signs such as retrogression of the positive breast changes that occurred during pregnancy, which is evident after a variable period following the death of the fetus. We can have on history, we can have, so the patient say before 20 weeks gestation, the most common finding is uterine fundus less than dates. So the uterus will be less than dates. Then per abdomen, what are you going to find out on per abdomen? So we can have gradual retrogression of the fundal height and it becomes smaller than the period of amenorrhea. So when you ask the patient the last MMP and the height of fundus, we find that the uterus is small for days. Then the uterine tone is diminished and the uterus feels flaccid, and the Braxton Hicks contractions is not easily felt. Then we have fetal movements are not felt during palpation, so you don't feel any fetal movements. Then we have fetal heart sounds, which is absent, and Doppler ultrasound is better than the stethoscope. So after putting a stethoscope, you won't feel anything, but the Doppler ultrasound will be better. Then, of course, you actually feel eggshell crackling feel of the fetal head, which is a rare feature, and of course, this one find it mostly during VE because you can't actually detect it, and so make sure you investigate properly for other things, but this is on per abdomen. Then we have investigations such as sonography. This is the earliest diagnosis. The earliest diagnosis is possible with sonograph, and the evidences are lack of all fetal motions under sonograph, including cardiac, during a 10-minute period of careful observation with real-time sonar, which is strong presumptive evidence of fetal death. Then the other is B for B, gradually oligohydramnios. So under the sonograph, we'll be able to note oligohydramnios and collapsed cranial bones are evident. Then, of course, after we do a straight X-ray abdomen, although it's rarely done at present, The following features may be found in varying degree, either singly or in combination. Then what are we going to see? We may be able to see a spouting sign, which is the irregular overlapping of the cranial bones on one another, which is due to liquefaction of the brain matter and softening of the ligamentous structures supporting the vault. Then it usually appears 7 days after death. Similar features may be found in extrauterine pregnancy with the fetus alive. So we also have other signs such as the bow sign, which is hyperflexion of the spine, which is more common, and in some cases hyperextension of the neck is seen, crowding of the rib shadows with the loss of the normal parallelism, and the appearance of gas shadows, which is the Roberts sign, in the chambers of the heart and great vessels may appear as early as 12 hours but difficult to interpret when detected, which provides conclusive evidence. Then, of course, other investigation you can do blood investigations to estimate the blood fibrinogen levels and partial thromboplastin time periodically, and when the fetus is retained for more than 2 weeks. So that's how it's going to help you. Then this is the sonographic plate, which is showing collapsed cranial bones, as he's saying here, which is a late feature of intrauterine fetal death. Then this is a straight X-ray of the abdomen, which is showing a single fetus. This is, as you can see, there is even some spine here. So it's a single fetus with marked irregular overlapping of the skull bones, which is the spotting sign, and of course there will be a hyperextension of the spine. So this hyperextension of the spine here. Then of course this is where the head is. Then we are done here. Then how do you evaluate a stillbirth? So we can have a methodological examination, which is going to consist of ABO and RH grouping, gray hour birth tests. We can have VDRIL, postprandial blood sugar, glycated hemoglobin, which is HB, A1C here. Then we can have urea, creatinine estimations, thyroid profile, so this is thyroid. Then torch screening, lupus, anticoagulant, anticardiolipin antibodies, and the thrombophilia studies. And you can also do urine examinations for casts and pus cells. So this is urine. Then thorough examinations of the fetus and placenta should be done. So I think this was supposed to be on another bullet, okay, not on hematological examinations. Okay, then the infant we have to evaluate the infant for malformations, umbilical cord for entanglements and number of vessels, placenta for N meconium staining, then malformations and the respective weight should be recorded as well. Then autopsy and chromosome studies are done for fetuses with anomalies and dysmorphic features. It is also done if there is history of recurrent stillbirth, or if either parent is a carrier for balanced translocation and fetal skin. Then blood are usually taken for cytogenic studies. Tissues must contain some viable cells. So this is just evaluation, but most autopsy should be done after you've delivered. Then what are the complications of stillbirth? So under complications of the stillbirth, we can have psychological upset, which often becomes a problem. Then we have infection. So long as the membranes are intact, infection is unlikely. But once the membranes rupture, which of course happens, infection, especially by gas forming organisms such as Clostridia myoshi, may occur. And the dead tissue, we know that the dead tissue favors their growth with disastrous consequences when the press is not sterile. That's when the dead tissue favors their growth. Then we also have blood coagulation disorders as complications. So this happens if the fetus is retained for more than 4 weeks. Then there is a possibility of defibrillation from silent disseminated intravascular coagulopathy, which is your DIC, and it is due to gradual absorption of thromboplastin liberated from the dead placenta and decidua, then which of course go into the maternal circulation. So that's how DIC comes about. Then we also have other complications such as during labor. Then we have uterine inertia, retained placenta, and postpartum hemorrhage. Then how do you prevent this condition? So the overall risk of recurrence of stillbirth varies between 0 and 8%. Then the conditions that run the risk of recurrence are: we have hereditary disorders, diabetes, hypertension, thrombophilus, placental abruption, and fetal congenital malformations. Can also have, then while IUFD cannot be totally prevented, the following guidelines may help to reduce its recurrence. So that's how we prevent recurrence. So we have preconception counseling and care, which is essential to prevent its occurrence in the high risk groups. Then we have prenatal diagnosis, so CVS or amniocentesis in selected cases. Then we have to screen the at-risk mothers. So we have mothers to attempt at-risk mothers during antenatal care, then care for assessment of the fetal well-being, and to terminate pregnancy with the earliest evidences of fetal compromise. Then we are done with prevention. So how are we going to manage? So after finding out you've made your diagnosis, the first thing you are going to do, of course, is you have to break the bad news to the mother and the family members, which is of course is a difficult task, and this is mainly due to the fear of being blamed for the poor outcome and for the medical or legal problems. Then of course you have to listen to the patient and family members actively, and then of course you have to answer their concerns and everything that to they want you to show clarity on, and you have to be professional and skillful for you to actually do this. You can even check out the video on how to break bad news, though it's on another case, but the skills and the data is just the same. You can even apply it there. Then we have expectant management, which is non-interference. So the patient and relatives are likely to be upset psychologically, but they should be assured of safety and non-interference. But in most cases, about 8% of them, spontaneous expulsion occurs within 2 weeks of death of the fetus, and the patient may remain at home with the advice to come to the hospital for delivery. Then whilst during this expectant management, fibrinogen estimation should be done weekly. So there will be spontaneous expulsion, then fibrinogen estimation weekly. Then what are some of the reasons why you should not do expectant management? So reasons for early delivery: we can have a reliable diagnosis could be made with real-time ultrasonography weekly. Then we can have prostaglandins if they are available for effective induction and complications could be avoided. These are some of the reasons why maybe you can do early delivery as compared to expectant. Okay, then what are some of the indications for you to do early interference? You can have psychological upset of the patient, which is the most common indication. We can have manifestations of uterine infection, tendence of tendence of prolongation of pregnancy beyond 2 weeks, and also falling fibrinogen level, which is a rare complication, which is a rare indication. Then how are going to deliver should be a mode of action. So vaginal delivery is our recommended mode of delivery, but of course you have to assess and you follow from the previous slide what we talked about, the indications for it delivery. Then so for aid interference, so vaginal delivery, specifically mechanical induction plus or minus oxytocin infusion, so you have to know how to induce. Then what would be your indication for C-section? So if there is a major degree placenta previa, severe cephalopelvic disproportion, previous classical C-section, and 2 or more previous Caesar, neglected or obstructed labor, uterine rupture, transverse or shoulder presentation, these are for C-section. So remember. So in induction or augmentation of labor. So what are we going to do? So a standard protocol for mifepristone or misoprostol induction is shown below. So we have to give, this is for medical is one which is mostly advised. Medical like I said in the previous slide. So mifepristone 200 milligrams, and you have to give it 24 to 48 hours before induction. Then after that you have to give misoprostol 50 to 100 micrograms PV 6 hours for 24 hours. And the membranes should be left intact for as long as possible, as the ascending infection can rapidly develop. Then previous C-section, the risk of uterine rupture is increased in induction of labor, and careful surveillance should be done even if you are doing mechanical methods. So if you are to do this in a previous Caesar, you have to do careful surveillance. Then in augmentation, if augmentation of labor, hope you know augmentation, because it's going to be confusing. So augmentation of labor, you have to manage similar to live birth, since the contractions have already started. Now I just want to stimulate, more like want to strengthen them, and you have to increase their intensity. So it's just managed similar to live birth. Then there are some points such as provide adequate analgesia, since you don't want to them. So this is a sympathetic approach. You don't want mother to go through the childbearing pain, labor pain. Then you can also give intrapartum antibiotic prophylaxis, but this should be done in women with sepsis, and they should be treated with intravenous broad spectrum antibiotics therapy, so which include antichlamydial agents. And like I said, routine antibiotic prophylaxis should not be used. So maybe some of the reasons we can use it should be maybe mechanical induction, which increases the risk of ascending infection in the presence of IUFD. So maybe if you are doing mechanical induction, it can even prevent infection. But routine antibiotic use should not be used. Okay. So after delivery, you are going to evaluate the stillborn baby, and of course postpartum examination. You try to find out why. Then bereavement and bereavement management and the puerperium. So the medical team and the nursing staff usually is the one which is going to provide all the support, sympathy to the bereaved couple. Then the couple should be explained in simple terms about the possible cause of fetal death. Then a psychologist or a counselor may see to support Also, then the recovery in postpartum ward is better avoided, because you can't put a mother who's mourning the death of a of a child, of a stillborn baby. You put them where others are, are with their uh, child who arrive. So when they are when that happens, it's going to create it's not going to reduce the psychological upset. It won't be reduced, so you have to avoid recovery in postpartum ward. And then the risk of postpartum depression is high if the couple is seen in the postpartum clinic after 6 weeks, and the investigation reports are reviewed and counseling for future pregnancy is done. So this is the bereavement management, and of course in the puerperian period. Then you also have to suppress lactation. So women should be advised that dopamine agonists successfully suppress lactation in a very high proportion of women and are well tolerated by a very large majority. Then so what are some of the dopamine agonists? So yeah, we can have cabergoline, which is superior to bromocriptine. So dopamine agonists should not be given to women with hypertension or preeclampsia. Then of course estrogens should not be used to suppress lactation. Then of course after delivery you have to engage them in their in contraception. Then follow up should be done, so you have to schedule a visit to the clinic. Then some of the differentials we can have for IUFD: we can have a viable pregnancy, that's not just maybe detecting whether the fetus is alive. Then we can have miscarriage, though here you have to know that there are a lot of miscarriages. There are those where there is, for example, complete miscarriage. So of course it can't be a differential here, because there's nothing there. The ultrasound not even detect anything. But there are those which are going to make sense here for differential diagnosis. Then you can have multifetal pregnancy, and then you can have partial molar pregnancy. And then that's the end of the story. Thank you so much for watching. Check out other videos if you are new to the channel. Subscribe, like this video, and wait for more videos. Thank you.